My name is Mohamed Hussein. I'm an upper GI research fellow from University College London Hospital in the United Kingdom. First, I'd like to thank the Endoscopy Journal for this opportunity to present our recently published paper on behalf of all of our co-authors titled Hemostatic Spray Powder TC-325 in the primary endoscopic treatment of peptic ulcer-related bleeding from a multicenter international registry. We all know that upper GI bleeds are a major cause of morbidity and mortality of up to 17%, and up to half of all of these cases are secondary to peptic ulcer-related bleeds. So the aim of this single-arm, prospective, non-randomized, multicenter international study was to assess the success of endoscopic hemostasis when hemospray is used in the treatment of these peptic ulcer-related upper GI bleeds. And a particular motivation of this study was that hemospray has been used for years, particularly in Europe and in the last couple of years in the United States. And there's no clear defined role within the GI bleed algorithm of where hemospray should be used or can be used. So the primary aim of this study was immediate hemostasis following treatment with hemospray, and secondary aims included hemostasis rates based on peptic ulcer location, based on Forest classification, 30-day rebleed rates, and 7 and 30-day all-cause mortality. And we collected data and performed the study in 14 centers in the United Kingdom, France, Germany, and also in the United States. And the decision to use hemospray was at the discretion of the endoscopist, giving us real-life, real-world data. And hemospray was used either as a single monotherapy, as part of a combination therapy, or as a rescue therapy. So in total, 202 patients with peptic ulcer-related upper GI bleeds treated with hemospray were recruited into the study. 77% of all these patients were Forest 1A and Forest 1B peptic ulcer classified ulcers. The majority of the bleeds were in the duodenum, and 50% of all patients were treated as part of a hemospray combination therapy. There was immediate hemostasis of 88% across all the groups of patients, with a 17% 30-day rebleed rate and a 22% 30-day all-cause mortality rate. And when looking at the monotherapy, combination therapy, and rescue therapy cohorts, the better outcomes seem to be when hemospray is used as a combination therapy, with slightly higher hemostasis, lower rebleed, but also a significantly reduced 30-day all-cause mortality when hemospray is used as part of a combination therapy. There was high immediate hemostasis rates with hemospray in all the Forest classification ulcers. And in the Forest 1A classification ulcers, there was a hemostasis rate of 87%. There was high hemostasis when hemospray was used in the esophagus relative to the duodenum, and this is likely due to the complex anatomy in the duodenum and the high-risk vessels in the duodenum as well. So the results of the current study suggest that hemospray may play a current role in achieving immediate hemostasis in high-risk bleeding peptic ulcers and may provide a bridge towards a second-look endoscopy or towards surgery or interventional radiological embolization. There also is a potential role for hemospray as part of a combination therapy cohort of patients, with also some promising results in the combination of hemospray and adrenaline therapy. But also there may be a particular role of hemospray in large peptic ulcer bleed sizes, but also in more complex anatomy such as in the D1-D2 junction in the duodenum, where they may be more difficult to apply therapy and also to get access with conventional modalities. And a short learning curve, but also easy use and easy widespread spray application of the hemospray powder may allow it to be used in such situations more easily. Obviously, more randomized controlled trials are required to validate some of these results, but hopefully some of the findings from this paper will help to support and guide more towards where hemospray should be used within the GI bleed algorithm in peptic ulcer bleeds. Thank you.